And hi, everyone. Thanks for having me. My name's Rachel, and I'm one of the SusQI program leads at the Centre for Sustainable Healthcare. So I will have said on your program that my colleague Kath Richards, who was also a SusQI program lead, would be presenting, but unfortunately she wasn't able to make it anymore today, so I'm here instead. For those of you who don't know, the Centre for Sustainable Healthcare is a charity that's based in Oxford, and we support the NHS and other healthcare delivery and also education institutions to integrate the values of environmental sustainability into healthcare teaching and delivery. And so one of the ways that we do this is through sustainability and quality improvement and our SusQI model. So today I'm going to focus on the what, why, and how of SusQI. So we'll look at what it is, why we recommend embedding sustainability into QI, and how through an example of SusQI and AHP practice. And then very briefly at the end, I'll go through some supports that you can access from us to support you to do this within your own QI education and practice. So firstly, what is sustainability and quality improvement? So it's the integration of environmental and social sustainability into quality improvement or QI education and practice. And so to be able to achieve this, sorry, I'm losing my voice a little bit. To be able to achieve this, we need to have a broader perspective of what value and quality within healthcare mean. And one of the ways that we can do this is using the sustainable value equation that's on the right-hand side of the screen. So we're, of course, still thinking about clinical and health outcomes for patients and service users. So at a very minimum, maintaining these, and obviously, if we can, improving these outcomes while reducing environmental harm, financial waste, and adding social value at every opportunity. And so social value can come through in lots of different ways, but a few examples on the screen are around improving convenience or experience for patients, and for staff, it could be improving their well-being or saving them time, making it easier for them to do their job. So the other thing we need to consider is our measurement. So to be able to demonstrate and share the impact that we've had, we need to think about environmental and social resource use in any potential improvement effort, and also think about what outcome measures we could use to show the changes in this resource use. So what is SusQI? So SusQI is a framework for embedding sustainability into quality improvement. It's based on the model for improvement, and it's not designed to replace any quality improvement methodology or tools or resources, anything that you already use, but it's meant to complement and integrate into anything that's already existing within your organization. And it is broken down into 4 steps you can see on the screen. So the first 2 are setting goals and studying the system, and these are often quite iterative. So you might start with a really broad goal initially to improve the sustainability in your service, for example, and then you would look at studying the system. So whether that is looking at an entire service, a specific patient pathway, a specific appointment or process, whatever it is, breaking it down in more detail to understand exactly how it works currently and where the kind of bigger problems or bigger areas of resource use are, to identify opportunities for improving that. And you can then go back and set more specific goals before moving on to step 3, which is designing your improvement and creating and developing the changes that you want to trial. And then the final step is measuring your impact. And so we'll go through a case study example that looks at these 4 steps a bit later. And so within SusQI, we recommend applying the principles of sustainable clinical practice to support you in identifying the most impactful improvements. And so the principles are listed in order of importance, with prevention in the top left first. So obviously, if we can prevent someone from becoming unwell or needing care or AHP services, whatever it is in the first place, that's the most sustainable that we can be. So this could be something like advocating the benefits of physical activity, healthy diets. An example of a preventative service could be a universal early years speech and language therapy service. So this is a service where children don't need specific referrals to access this support, but there's a speech and language therapy team that provide training to parents and early years practitioners about early childhood development and speech and language development, so that they can optimize the language environments that children have access to, and also so that any signs of difficulty can be recognised and supported sooner rather than later. Next is patient self-care and empowerment, so on the top right-hand side. So this is really key for any form of therapy and likely something that you already are supporting through your everyday roles as an AHP. So one example would be to engage a patient in a prehabilitation exercise program before they have a surgery to improve the recovery and outcomes that they have post-surgery. Third is lean service delivery. So this is streamlining systems or patient pathways or specific resource use to minimize wasteful activity. So this could be reducing the number of tests a patient needs to have or the number of appointments that they come in for if these appointments aren't actually adding real value to that patient. Fourth is low carbon alternatives. So this involves things like switching from single use to reusable items. And so you can think about these principles within your own services and quality improvement, but they also align with more national programs as well. So something like GIRFT, getting it right the first time, likely feeds into a combination of these principles. And there is a fifth principle that's not on the slide, which is about operational resource use. So things like energy, water, and waste disposal. So why do we need to think about integrating sustainability into quality improvement? So firstly, because climate and environment are inextricably linked to our health. So on the screen is an infographic that shows the biggest climate change impacts in the centre. So rising temperatures, more extreme weather events, rising greenhouse gas levels and rising sea levels. And then in the 10 coloured boxes around that you can see more specific environmental impacts. So for example, on the top left, air pollution and increasing allergens, and then how these more specific impacts can be harmful to our health. So I'm not going to go through all of these, but as you can see, the impacts both to the environment and then to our health are really widespread and varied. And this isn't an exhaustive list. So for example, there are links between air pollution and extreme heat and the incidence of stroke, but stroke isn't something that's here on the slide. We also know that these impacts are greater in vulnerable populations. So that could include those with chronic health conditions, those with low income, from non-white and Indigenous communities, also for children and the elderly, pregnant women. And so we can't have climate justice without social justice. And so this might also be relevant for patients and service users that you work with. And while we all want to promote health and well-being, we're also working within an unsustainable system that contributes to all of these problems. So if global healthcare were a country, it would be the fifth largest emitter in the world. And in the UK, the NHS contributes 4% of the whole UK's carbon emissions, which is equivalent to entire countries' emissions like Croatia or Denmark. And so while carbon isn't the only problem, and you can see a few other examples on the screen, so related to medicine pollution in rivers and plastic pollution, carbon footprinting is currently the most comprehensive measure that we have to bring different environmental elements together in a way that's measurable and comparable within different projects or over time. And so this is why we talk quite a lot about carbon footprinting. And the NHS has set an ambitious and a legally binding target to be net zero, so emitting no carbon by 2040. And so each NHS trust has a green plan to meet these targets. So a lot of healthcare professionals are often very concerned about climate and ecological crisis, but they're not really sure what they can do about it within their workplace and role and don't really feel like they have the agency to create changes. And I think one of the reasons for this is because we often think about environmental sustainability as something that's someone else's job. So we care about it, but we think it sits within estates and facilities departments. And there's a specialist who knows about the environment who'll make those changes and reduce those impacts. But we know that the majority of carbon emissions attributed to the NHS are heavily influenced by clinical decision making. And so the pie chart you can see on the left-hand side gives a breakdown of the carbon footprint of the whole of NHS England. And so in the pie chart, you can see that about 60%, so this whole section here, is from medicines, medical equipment, and supply chain. And so all of these things are coming through that supply chain to be able to provide care. And so to meet these net zero targets, clinical healthcare workers are essential. We're not going to be able to do it without working together rather than working in silos. And because quality improvement is the framework used for change in the NHS, it makes sense to bring environmental sustainability into quality improvement as a way to make this more accessible and understandable for clinical healthcare workers. Um, So in addition to reducing the environmental harm, we know that environmentally sustainable care is high quality care. And so it aligns with social value, with personalising care and with tackling health inequalities. And hopefully this slide gives some examples of this. I don't know if it's readable, so I apologise if it's quite difficult for you to see. I think we'll share a copy of the slides after as well, so you can have a look at the model in more detail. And I'm not going to go through the whole thing now, but on the left-hand side, here you can see that overall, if we're thinking about reducing carbon emissions, there's a list of actions that we can take. And then on the right-hand side, you can see some of the health benefits and the social equity benefits of these actions. And so if we look first at the first three actions. So sorry, it's also really small on my screen. So if we can use more renewable energy sources, if we can increase active travel, such as walking and cycling, and increase use of public transport, we're contributing to reducing air pollution, which then in turn can go on to reduce rates of asthma, COPD, lung cancer, heart disease, stroke, obesity and diabetes, dementia, depression and anxiety. The list goes on of reducing air pollution can have really widespread impacts and co-benefits for our health, but also for reducing social and health inequalities. So if we just took asthma as one example, asthma rates tend to be higher in more deprived areas. So I live in London, and asthma rates are higher in more deprived areas of London. And so if we can reduce air pollution, we can actually start to reduce some of that inequality around asthma care. And so lastly, as I mentioned before, we often talk to clinical healthcare workers who are really worried about these issues, but don't feel that they know what to do. And that can be really, really overwhelming and really demotivating. And so we ran an evaluation of SusQI education tools a few years ago with medical, nursing and occupational therapy students. And what the evaluation found was that SusQI teaching and resources helped to provide a concrete way to make a difference rather than just learning about the problem, which went on to provide increased motivation for improving care and for quality improvement processes. So it was really key in taking this knowledge about a problem and translating it into action, which is really what we need. So I'm going to give an example of SusQI in practice now. And so this is from a really recent project undertaken by the speech and language therapy team at Great Ormond Street Hospital in London. And so the team started with an overarching aim to ensure the sustainable use, reuse and disposal of alternative and augmentative communication, or AAC devices, that were provided to children and young people across their service. So some background for some of you who might not have heard of AAC before. So alternative and augmentative communication, or AAC, refers to methods and tools that are used to support communication. So that's for individuals, in this case children and young people, who have difficulty speaking and or understanding language. And so it covers a wide range of techniques. It can include gestures, sign language, picture-based communication boards, and also computer-based high-tech systems. And so the team who undertook this project are a tertiary specialist AAC service. And so a child or young person will be referred into their service from their local speech and language therapy team for more specialised assessment for a communication device. So in this case, it was often a communication app on an iPad or some sort of high-tech computer device. And so the team provide equipment and training, as well as ongoing maintenance and support for these communication devices. So through this, oops, sorry, I've skipped a slide. So the team started by completing a process map first of their device learning process. So it started with the provision of a device to a service user here on the left. Don't worry too much if you can't read all of the detail. That's okay. We'll go through it. But so started with provision of a device, and then throughout the process map various considerations of what happens once a child or young person is given a device, including how the team would review it, and then what happens to the device when it was no longer operating or being used functionally in the black circles on the right side. So through this process, several issues were identified. So first, not all children who are given a device go on to use it at all or effectively, which means there might be an iPad or a communication device sitting around not ever being used in a patient's service user's home. So this leads to suboptimal patient outcomes and contributes to financial and environmental waste. So under the current process that the team reviewed, they recognised that they were not reviewing devices until the service user had had that device for 24 months, which could be too late to address some potentially smaller usage issues that could have helped that service user to access and actually have more use of the device much earlier. Or it could have been identified that the device wasn't actually appropriate or going to be used by the service user sooner, and it could have been returned to be used by someone else. So the team also found they frequently courier devices back to GOSH to be taken for repairs, and some of these repairs could be avoidable or done locally with the patient and their family if they had been given additional support or education in how to do some of these repairs themselves. Thirdly, the team had a low device return rate, so about a quarter of their devices were currently being returned, and there was little within their current process to encourage service users to return unused or broken devices. And once the devices are returned, they were either sent back to the manufacturer, they were given to a child with a history of breaking devices, or they were kept by the team for assessment. But the team identified they had 25 devices in their assessments and loan cupboard that they were never using. So they set four more specific aims. So first, to improve the device return rate for unused devices, to extend the lifespan of long-term devices, which at baseline was about four years, to reduce the courier journeys to GOSH for device repairs, and also to donate devices to local SLT services. So sorry, speech and language therapy SLT services when they're no longer suitable for service users or required by the team. And so they use the principles of sustainable clinical practice that I mentioned earlier to think about changes they could make. And so in terms of patient empowerment and more broadly family empowerment, preventative troubleshooting performer was given with all new devices. And then the device was reviewed via email 6 weeks after issue. And so the aim was that this could reduce the number of courier journeys needed for repairs and could improve device use by identifying any potential issues really early on. They also moved their review from 24 months to 12 months to catch issues sooner. They considered extending lifespan of devices by developing a criteria to support decision making for extending these. So balancing the device, kind of how old it was, how often it had been used previously with the actual needs of the patient as well. And then they had a plan for a local SLT information morning. And so at this information morning, they wanted to support education around how to use different devices and communication apps. But they also wanted to donate the devices that they weren't using to these local services. And I'll go through why in the next few slides. And so in terms of measuring impacts, the team did consider the full sustainable value equation. So they considered measures for clinical, environmental, social, and financial impacts. I'm just going to focus on environmental and social for the presentation. But in terms of environmental measures, the team are going to continue to measure how many devices are loaned per year, so including what type of device it was and the software that the service user was given, how many are returned per year, how many courier journeys they have to GOSH for repairs and the distance of those journeys, and for those things, an emission factor, so for an iPad or a device, for the software and for the courier journey, can be used to translate the savings or the difference as a result of the project into a carbon footprint or a CO2 saving. And they're also going to look at whether their devices, once they come back, are recycled, returned, or donated to local services. And so this isn't something that will carbon footprint as it's expected. Even if donations to local services do increase, the device will still eventually, even if it's say 5 years later, will still be disposed of in the same way. So it would still have the same disposal emissions, just at a later point and associated with a different team. In terms of social impact, so the team already did capture some data before the project, but also through their environmental measures are capturing data on their troubleshooting and use of devices, so how many patients are using or not using their devices. And so that will provide indirect feedback on whether service users and families have been more confident to repair devices. So also by looking at whether their courier journeys have reduced. They're going to look at the time that the team spend troubleshooting to see if this reduces through more patient and family empowerment. After the information session and provision of devices to the local SLT services, the team want to review the local SLT satisfaction and self-rating of skills and confidence via a questionnaire. And they also want to look at whether their number of inappropriate referrals changes. So they did recognise also through that study, the system process map, that they actually have quite a high rate, about 50% of the referrals that come through are inappropriate. And so they wondered if support to local speech therapy services could reduce that, and I'll go through why in a minute. So in terms of outcomes, like I mentioned, this is a really recent project from our Green Team competition. So the team only had 10 weeks to look at all of this, and they now need about 6 to 12 months to monitor how this is going and actually then collect their post-change data. So this is their projected savings, so what they're hoping to achieve based on their changes, and in 6 to 12 months we'll be able to look at whether they have achieved this or actually exceeded it or not quite met the targets they were aiming for. But so clinically, for patients who are no longer using devices, if they're identified sooner, they can be reassessed sooner and then be issued with a more suitable device. So that can improve patients' communication, both at home and at school, which is beneficial for their well-being and also for their education. Financially, the team are looking at savings of about £6,000 across a year, and so it's predicted that the majority of this will be from repurposing 4 additional devices and software per year, which means that they'll have 4 less devices and software to buy brand new, and a smaller amount from reducing the number of courier journeys for repairs. The team have already repurposed 1 device, so they've prevented 1, and so they expect that 4 across the year is quite achievable and realistic. Environmentally, the reduction of 4 new devices and software per year and the reduction of 1 courier journey per fortnight equates to savings of 772 kilos of CO2 equivalent, which is equal to driving about 2,280 miles in an average car. And then socially, for local SLTs, for teachers and parents, by giving this kind of troubleshooting performer to identify and prevent simple issues, they expect that this will be empowering and it will reduce delays to accessing devices if service users are needing to wait for that device to be sent to GOSH to be repaired and to be sent back. It could reduce troubleshooting calls to the GOSH tertiary service, saving their staff time, and then donating old devices to local speech therapists rather than back to manufacturers provides local teams with resources they wouldn't otherwise have access to. So often local speech therapy services won't have the funding to buy and keep devices handy around to use for their own training or to trial with patients. So by donating these devices, local services can have access to this support as well. And so that could be beneficial for local SLT confidence and job satisfaction, but also more broadly for service users and could feed into reducing the number of inappropriate referrals that service receive as well. So I'm not going to go through more case studies, but I just wanted to flag that we've got an additional 3 green team competition teams presenting across this week. So unfortunately, 2 of the presentations were yesterday's, but they will have been recorded. So if you didn't have a chance to see them, I recommend going and listening to the recording. So one of the teams is a hand therapy team that looked at changing their patient pathway to improve outcomes for patients following hand surgery. The next team looked at similar, so making pathway changes by providing specialist physiotherapy to limb reconstruction patients, which found that they could then have the frame around that's supportive of their limb reconstruction removed sooner, leading to better patient outcomes. So both of those presentations were yesterday. But yeah, I encourage you to have a look at the recordings for more examples of SusQI. And then lastly, this team, I believe, are presenting on Friday. So this was an ODP team, operating department practitioner team, who looked at switching from single-use to reusable surgical gowns, and also looking at using remanufactured devices. So devices that are initially bought new, then they're sent back to a remanufacturer who processes them so that they can be used a few more times before they're disposed, rather than being single-use. So that's on Friday. We have a huge range of SusQI case studies hosted in our resource library, which is within our Sustainable Healthcare Networks. So the links to the networks is coming up in a few slides, and I believe it's shared on all of the presentations throughout this week. I'll confirm that with Sam at the end. But we also got about 30 different specialty networks. So I encourage you to have a look at those and join those. So there is an allied health network, there is an occupational therapy network, and there is a speech and language therapy network. If you're looking for support or want to think about your own SusQI projects, or actually want to share and teach about SusQI to others, we've got a lot of open access resources on our SusQI website. So you can see in the Green Team competition, which is where these case studies come from. So there's a lot of case studies and information about the competition there. But actually, if you go to the step-by-step guide, is where you'll find some resources for actually thinking about your own service, looking at process maps, studying the system, thinking about where some of those carbon hotspots or areas of high resource use might be, and then also models for helping you to think about impactful changes using the principles of sustainable healthcare. So I recommend taking a look at that. There is also, I don't think I can see it on the screenshot, but there is also on the website, you'll find an educator pack, which has slide sets and different tools and resources for educating others about SusQI as well. And lastly, one of the tools that you'll find on the SusQI website that's available for free is a carbon footprinting guide. So if you're interested to learn more about carbon footprinting, I recommend you take a look at that. So it gives you a bit more information about why we carbon footprint, how we do it, and it's also got some helpful emission factors in the appendix. Finally, we do have some paid programs as well, so I'm happy to answer questions if anyone has about those, or please get in touch with me if you've got any questions about our courses or our competitions or our SusQI Academy. And so the Academy is working more with quality improvement teams to look at embedding sustainability into quality improvement through an organisation. Yeah, I'll leave it there with some resources. Thank you. And yeah.